Welcome to our discussion on miscellaneous arthritis. This chapter delves into a spectrum of arthritis conditions encompassing gout, pseudo-gout, polymyositis, dermatomyositis, and various compression neuropathies. Each of these conditions presents a unique set of challenges affecting different joints and tissues, thereby leading to a diverse array of symptoms and treatment approaches. It's imperative to grasp the distinguishing features of each condition to ensure accurate diagnosis and implement effective management strategies. Let's explore the intricacies of these conditions together. Let's compare gout and pseudo-gout. Both are crystal arthropathies, yet they differ in the type of crystals that accumulate in the joints. Gout is characterized by the deposition of monosodium urate crystals, whereas pseudo-gout involves calcium pyrophosphate dihydrate crystals. In terms of presentation, gout typically manifests in the big toe, whereas pseudo-gout more commonly affects the knee. However, both conditions can overlap in joint involvement. Additionally, gout is predominantly found in male patients, while pseudo-gout is often associated with hyperparathyroidism. Managing chronic gout involves a multifaceted approach. Initially, conservative measures are recommended, including lifestyle modifications and addressing any underlying metabolic issues such as insulin resistance, hypertension, or obesity. Lifestyle changes like reducing alcohol and meat consumption can also help prevent recurrent gout attacks. If conservative management proves insufficient, medication becomes necessary. Several drug combinations are available to prevent recurrent gout episodes. These may include xanthine oxidase inhibitors like allopurinol or febuxostat combined with colchicine or probenecid combined with colchicine. In terms of acute treatment for gout attacks, NSAIDs or steroids are typically the first-line options. However, in cases where multiple joints are involved or the patient cannot tolerate NSAIDs or steroids, colchicine may be used as an alternative. Polymyositis and dermatomyositis are both inflammatory conditions affecting the muscles, resulting in weakness primarily in the proximal muscle groups. They share common diagnostic criteria, including difficulties with rising or descending from a position, swallowing issues, fatigue, and elevated markers of muscle inflammation. However, the key distinction lies in visible skin manifestations, which are characteristic of dermatomyositis but absent in polymyositis. Dermatomyositis often presents with the heliotrope rash, the Schall sign, and Gautron's sign. Additionally, dermatomyositis is associated with an increased risk of malignancies compared to polymyositis. Treatment for both conditions typically involves the use of steroids, but the approach may vary depending on individual cases and any complicating factors present. Polymyalgia rheumatica, PMR, and temporal arteritis are distinct yet often interconnected conditions. PMR primarily affects the girdle muscles, resulting in weakness, pain, and stiffness in the shoulders and hips. Interestingly, about half of PMR cases coincide with temporal arteritis. Temporal arteritis, on the other hand, entails inflammation of the blood vessels, particularly the cerebral artery. It's crucial to note that temporal arteritis constitutes a medical emergency due to its potential to cause permanent vision loss if left untreated. Symptoms may include headaches, jaw claudication, tinnitus, and abrupt changes in vision. In terms of treatment, PMR typically responds well to low-dose steroids, whereas temporal arteritis necessitates high-dose steroid therapy. When both conditions coexist, high-dose steroids are initiated to address them simultaneously. Unlike polymyositis and dermatomyositis, PMR does not involve elevated creatine kinase, CK levels, or necessitate electromyography, EMG, or muscle biopsy for diagnosis. Carpal tunnel syndrome, CTS, and tarsal tunnel syndrome, TTS, present as compression neuropathies, albeit affecting different nerves, the median nerve in CTS and the tibial nerve in TTS. Despite their anatomical variance, Both conditions follow a similar management trajectory, commencing with conservative measures and escalating to more invasive interventions if required. Diagnostically, CTS is identified through tests like Tinel's sign, Phelan's maneuver, and the hand elevation test, whereas TTS diagnosis primarily relies on Tinel's sign of the ankle. Underlying causes can contribute to nerve compression in both syndromes. In CTS, factors such as amyloidosis, hypothyroidism, or acromegaly may restrict nerve space, while neurofibromas commonly underlie TTS. Systemic lupus erythematosus, SLE, is a multifaceted autoimmune disorder with the potential to impact various organ systems spanning neurological, dermatological, pulmonary, cardiovascular, renal, musculoskeletal, and hematological domains. Diagnostically, SLE is characterized by a spectrum of markers including positive ANA, anti-dsDNA, anti-phospholipid antibodies, and low complement levels. Notably, antihistone antibodies lack specificity for drug-induced SLE. In contrast to idiopathic SLE, drug-induced SLE tends to manifest with milder systemic effects, primarily affecting the cardiovascular, pulmonary, and musculoskeletal systems. Symptoms often resolve upon cessation of the causative medication. With diligent medication adherence, the prognosis for SLE is optimistic, as it is a condition that, while chronic, can be effectively managed. Skin involvement is a key factor in distinguishing between diffuse and limited scleroderma. In diffuse scleroderma, the sclerotic skin distribution is extensive, affecting the trunk and extremities, while in limited scleroderma, the skin involvement is predominantly localized to the hands and face. The autoantibody profile further aids in differentiation, with diffuse scleroderma often associated with anti-topoisomerase I SCL70 autoantibodies, while limited scleroderma tends to exhibit anti-centromere autoantibodies. Treatment and prognosis for both forms of scleroderma typically involve the use of nifedipine, a calcium channel blocker, to mitigate vasospasm and dysmotility associated with the condition. Fortunately, the prognosis is generally favorable, with a higher prevalence observed among females. Spinal stenosis and spinal disc herniation are distinct spinal conditions with different underlying causes and presentations. Spinal stenosis involves a gradual narrowing of the spinal canal, often attributed to conditions like rheumatoid arthritis, osteoarthritis, or spondylolisthesis. This narrowing can result in symptoms such as neurogenic claudication, paresthesia, and in severe cases, cauda equina syndrome. On the other hand, spinal disc herniation, commonly known as a slipped disc, occurs when the inner contents of the spinal disc protrude outward, potentially compressing nearby nerve roots and causing symptoms such as sciatica. The Laseg test, which involves raising the leg while lying down, is a helpful diagnostic tool for identifying spinal disc herniation. Initially, both conditions are managed conservatively with approaches like physical therapy and nonsteroidal anti-inflammatory drugs, NSAIDs. However, surgical intervention may be necessary for severe or refractory cases. For spinal stenosis, procedures like laminectomy may be performed, while spinal disc herniation may require a discectomy to alleviate pressure on the affected nerve roots. Ankylosing spondylitis is a chronic inflammatory arthritis primarily affecting the axial skeleton, including the spine and sacroiliac joints. One of its distinctive features is the fusion of vertebrae, resulting in the characteristic bamboo spine appearance. Unlike rheumatoid arthritis, ankylosing spondylitis is seronegative, meaning it lacks rheumatoid factor. Instead, it is strongly associated with the HLA-B27 genotype and elevated inflammatory markers such as ESR and CRP. In addition to joint involvement, ankylosing spondylitis can manifest with various extra-articular symptoms, including anterior uveitis, inflammatory bowel disease, psoriatic arthritis, aortitis, and rhythm disorders. The management of ankylosing spondylitis typically follows a stepwise approach. Initially, NSAIDs are used to alleviate symptoms and reduce inflammation. If NSAIDs are insufficient, disease-modifying antirheumatic drugs, DMARDs, may be prescribed. In severe cases, steroid therapy or joint replacement surgery may be considered to manage symptoms and improve quality of life. Sjogren's syndrome is a chronic autoimmune disorder that primarily affects the moisture-secreting glands, resulting in symptoms of dry eyes, xerophthalmia, and dry mouth, xerostomia. A key diagnostic tool for Sjogren's syndrome is the Schirmer's test, which measures tear production. Additionally, the presence of positive autoantibodies such as anti-Rho and anti-LA is characteristic of the condition. Patients with Sjogren's syndrome have an increased risk of developing lymphoma, although this is not a common occurrence. The treatment approach for Sjogren's syndrome primarily focuses on supportive measures. This includes the use of artificial tears and sugar-free gum to alleviate the symptoms of dry eyes and mouth. Fibromyalgia is a chronic pain disorder characterized by widespread musculoskeletal pain, paresthesias, sleep impairment, cognitive impairment, and chronic fatigue. Despite common misconceptions, it is recognized as having objective findings. The diagnosis of fibromyalgia requires a history of pain lasting more than 3 months and the presence of 18 symmetrical trigger points distributed throughout the body. Although not classified as a neuropathic pain disorder, patients with fibromyalgia often find relief from neuropathic pain medications such as gabapentin, pregabalin, or tricyclic antidepressants. Complex regional pain syndrome, CRPS, is characterized by pain, swelling, and rapid bone demineralization, often triggered by a traumatic or surgical incident. Patients with CRPS may experience vasospasms, swelling of the affected extremity, and the development of osteoporosis, which can precede the onset of full-blown osteoporosis. Initial management of CRPS typically involves conservative measures like physical therapy and NSAIDs. However, in severe cases, more invasive interventions such as regional nerve blocks or radiofrequency sympathectomy may be necessary.